Well, hello and welcome to a podcast summarizing the key messages from the recent webinar, CAR T-cell therapy and emerging therapy in autoimmune diseases. Well, my name is Iain McInnes. I'm Vice Principal, Head of College of Medical Veterinary Life Sciences in the University of Glasgow. And I am joined by Professor Georg Schett, Vice President of Research, Head of the Department of Rheumatology and Immunology at the Friedrich Alexander University Erlangen-Nuremberg Hospital. But actually, the real truth is that Georg and I have been friends for more years than either of us will ever admit to. I think we started writing together more than 2 decades ago, Georg. So what a joy it is actually just to get the chance to have a little chat in this podcast. So warm welcome to you.
Thank you, Iain. I'm very happy to do this podcast with you. Really a pleasure. Yeah.
It is. And as ever, it's probably me that's going to learn and ask. I'll be learning while I ask the dumb questions. So not a lot has changed over more than a couple of decades when I think about it. And we're going to highlight some of the key elements that came through in a webinar, which if you want to look at it, folks, go across to IMID Forum and you'll be able to pick it up. It was originally recorded on 6th November 2024. I had the pleasure of chairing it, but the real stars of the show were Carl June, Rich Fury, and of course, my dear friend, Professor Georg Schett. Today, I'm going to very briefly summarize what we talked about, but the main event, if you like, is just thinking out loud with Georg about what CAR T cells might mean for those of us interested in immune disease therapeutics and potentially the future. Really start to think about immunologic reset. And it's timely, isn't it? Because over the last decade, we have dared to dream. We've started to talk about long-term remission. We've talked about maintenance of drug-free remission. And the logical progression for that is obviously, well, what could the CAR T cells and indeed maybe even other mechanisms of B-cell depletion take us in that direction? And in the webinar, we had the pleasure of listening to Carl. Carl June is one of the pioneers of the whole CAR T cell field, really. And he talked a little bit about CAR T cells as a process rather than, inverted commas, just as a drug. He reflected in the origins of CAR T cell therapeutics coming from the hem-oncology world. And of course, this was particularly in pediatrics, young adults, but in fact, the case history have grown right across the age range. He talked a little bit about first and second generation CAR T cells, the evolving generations being manipulation of the chimeric T cell antigen receptor. The idea that these are molecular constructs. So there's an engineered molecular product that is placed into a T cell, and then that T cell has effector biology, which is used as the therapeutic, if you like it. It's quite often a killer cell. And that, in terms of large population cellular depletion, we've got a whole lot of, for example, malignant B cells. They turned out to be really useful to deplete those large volume B cell malignancies. And in fact, patients have undergone long-term remission and in some cases, persistence of the CAR T cells for more than a decade or so. He talked a little bit about the next generations coming yet again. He talked about truck armored car. I'm not going to go through the details because I'm desperate to get to autoimmunity, but I think just be aware as you listen to the podcast, as you listen to your thinking out loud about what might be possible in autoimmunity, that this field is changing fast. And I imagine in a few years, we might look back and say, do you remember we used those CAR T cells and now we use these CAR T cells? Wow, weren't we stupid? Well, let me tell you, nobody was stupid in this business. It was really beautiful science that took us where we're going. And the final thing I guess I'd mention from Carl's presentation, he also talked a little bit about applications in solid tumors and highlighted the advent of therapeutics in glioblastoma. And there's a therapy that we desperately need, don't we, in the glioblastoma field, and also advances in lymphoma. But then we had the pleasure of listening a little bit to Georg, thinking out loud about this really extraordinary revolution and the potential role that CAR T cells might play in autoimmune disease. So, Georg, at this point, I'm going to kind of step back now and just suggest that you spend a minute or so thinking out loud about the motivations you had, the kind of therapeutic options, and of course, landing on the CAR T therapeutics. So maybe over to you, and I'm all ears.
Yeah, thank you, Iain. I mean, I think the one fascinating story in this development is that you create probably one can create probably new concepts, right? And we always consider as rheumatologists or nephrologists or neurologists, dermatologists, right, that an autoimmune disease is given and you can't get rid of it, right? And we have learned that we have to control it, yeah, and all our efforts are to control autoimmunity, control inflammation, bring the patient into remission. But that's good, and there has been a massive development in this field in the last 2 decades. But then I think we are now pretty good in many patients to control the process. Not in all, of course. There are very resistant patients also. But the next step, and we should, I think, when we are academic doctors, we always think what was next? Can we do something better, right? And the idea is always, can you really get rid of the disease? And how can you do that? And I think this is an aspiration. We are not there, right? But I think CAR T-cell therapy has given a new view that you might do that, right? It is principally possible, and it's not something you're not allowed to think of. And I think that's for me the most fascinating aspect in this field. It's in its infancy. But it's possible, and I think what is fascinating that the technological progress is so substantial, right? I mean, we probably would have not, you and me would not have believed in the early 90s that you block one side to kind of like TNF and everything breaks apart, right? quite fascinating story, right? And I think most of the people didn't believe in that, and I think we are probably somewhere here in the next step that we learn how to use these kind of tools in a better way, and the current tools may not be the ones used in 10 years, right? There is an evolutionary process in that technology, but I think the general concept is interesting. And for me, when I see the first patient after 3.5 years, she is not a patient anymore, right? She is coming and she is just a healthy young woman. And that's for me extremely fascinating. And this is a healthy young woman, goes on the beach now, right? And have lupus, very severe lupus, right? And I think this is a role model for others. I think it is not I think the aspiration often is to say 100% efficacy, 0% safety. That's not realistic in a human system, right? In a human system, there's always some people don't work, and some people relapse, and some people are super responders. It's actually very chaotic. But I think we should have always realistic expectations, right? I think we see that this is possible in some patients, not in all. And we have to learn how to improve that technologies. And I think that's the most fascinating aspect in this field.
So well, first of all, thank you. But I completely agree that I think what your work has offered us so far is a glimpse of what might be possible. And, Rich in the webinar talked a little bit about, he talked about other mechanisms. I think you acknowledge, and that would be great. And the technology is, of course, going to advance. And we now see, even in the antibody field, we've got nanobodies, and they actually do seem to have different pharmacodynamic tissue penetration properties, and potentially therefore different potency. In the cell therapy, we'll see similar advances. But the value of the conceptual advance, that a long-term sustained remission, whereby patient is returned to person, is possible.
Yeah.
And we've seen that, actually, if truth be told, we've seen it with some of the extraordinary responses, even to some of the cytokine targeted antibodies. But what feels different here, Georg, is the concept of you go in with an established therapeutic regimen, but then you step back. And so far, it's really only a very small proportion of patients in the cytokine-directed therapeutics from whom we can step back with no drug therapy. This feels a bit different. Am I overstating what you're thinking here?
No, I fully agree. I mean, there are also, we see super responders, and there are also rituximab patients. They have one infusion and then they have probably long depletion and they're doing extremely well for a long time. But that's more the exception from the rule, right? So I think the interesting part will be how can we increase that super response, right? And where we can stop the therapy. That is interesting. And I mean, there has always the paradigm that rituximab might not be ideal because the plasma cell may step in and you don't deplete them and they trigger the disease. And I think what CAR has learned, or CAR T-cell therapy has learned, that it's not only the plasma cell story, right? It's just an inefficient depletion regimen. And if you improve the depletion, no matter how, with a CAR, with a bispecific or a T-cell engager, or with a super high affinity antibody, you're better, right? And the obinutuzumab, as Rich has pointed out, actually show that also in a way, right? That the higher affinity CD20 antibody does better than rituximab in showing clinical efficacy in a study. And that's, I think, I think that has been really very much pushed by the CAR field, that this thinking changed and they say we should just be better in our tools to deplete B cells in this disease.
And also, yeah, no, very much so. And you made the point in your webinar, and I'm going to refer people listening to the podcast to go back and have a listen to the webinar. Georg's presentation, all the presentations were fabulous. But just the immune system does not sit functionally with these careful compartments that we draw cartoons about and give immunological ontologic names to. Yeah, the B cells are designed to work with the dendritic cell compartment, with the other myeloid lineages, with T cells. And I think what the CAR T therapeutic regimens are going to teach us is probably also some of the critical dependencies that they have on other cellular systems. And you talked a little bit about the lymph node. Lymph node is an extraordinary and dynamic structure. People, let me tell you, swollen glands gives absolutely no recognition of the extraordinary, exquisite geographical and spatial complexity of what the lymph node does. And I think, you guys are starting to see some really interesting changes in lymph node structure and perpetuity of function. So again, I really entice you to say a little more about that, if you would.
Yeah, I mean, this is a very nice example you raised, and in a way, it brings me again back to the TNF, right? I mean, why does an anti-TNF work, right? It's probably not because it blocks only the TNF, right? Because when you only the TNF as a single molecule would go down, probably the autoimmune disease wouldn't change, right? But much more is going down, right? And then just TNF, other cytokines are going down, and this shows this critical interdependence. And I think to explain the long-standing CAR T-cell mediated effect in autoimmunity is based on not only on B cells, right? I mean, the B cells are the anchor where the drug works, but then you can see that the B cells are orchestrating other cells. They are orchestrating T cells. T cells are obviously dependent very much on a continuous B cell stimulation. And then I'm sure that there is also an effect on the myeloid lineage, right? To some extent. The question is for instance, this imprinting of the myeloid lineage due to inflammation also reversible by such an approach? These are all questions I think which can be addressed in the future and extremely interesting. So I agree with you. What I think that the reset concept is always to create, I think, a homeostasis, a tissue homeostasis again, and kind of a tolerance of a system, which can not be perturbed so easily. Even when you go into the sun, this system is rather stable, right? So there's a new level, a new homeostat, which is actually created. And I think this is super interesting and not completely understood how this works.
Yeah, you're reading my mind here, Georg. What a lot of this work has got me thinking about is just where are the critical immunological sensors? Your car has a sensor for is there air in the wheel, or is the engine oil too hot, or whatever. So I suspect we're probably going to start to learn about immunologic sensors. Now, at one level, yeah, it's easy, and it's the checkpoints. Of course it is. There's checks and balances built into every response, and that's kind of that's a relatively basic tenet of immunology that most of us have thought about for 30 or 40 years, particularly those of us who started thinking at a very, very young age, just for the record. But I think that idea of what are those sensors that must be dysregulated to allow recurrence of autoimmunity, we need to identify those, because you could actually imagine a scenario where you give the CAR T reset and then start to think about, well, and how do we get the maintenance? How can we safely get maintenance? Can we predict those who don't need it, the super responders? Can we start to identify those who just need that careful immunovigilance? And you know, that for me is just an extraordinary part of our future. You know, Georg, let me just, I want to, the next thing I want to ask you actually is about, so I was also gratified to see the depth of response in some of the other immune-mediated inflammatory diseases that I think both you and I, for our whole careers, have worried about. Scleroderma, some of the myositis, myopathy conditions, for which the outlook can be pretty grim, and for which existing therapies are really very, very troublesome. Maybe just think out loud about that, because that for me has been one of the other real learnings of the last 3 or 4 years in the CAR T autoimmunity story.
Yeah, I mean, that's a very interesting finding, right? That also systemic sclerosis patient respond pretty well, right? And also those patients with severe myositis, interstitial lung disease, and it creates also a new concept, because I mean you can now, meanwhile, you have the tools to check actually the fibroblast, the mesenchymal activation in vivo in humans with the FAP PET, right? Which allows you not to see inflammation, but you see tissue response to a problem, right? So this scan shows you there is a problem and the tissue response. And the fascinating part is that you get an almost complete abrogation of the FAP signal in these patients with systemic sclerosis and myositis after CAR. So it shows that there must be a very intimate link between this B-cell activation state or autoimmunity and these tissue responses, right? Which is very fascinating. And also has not been expected, right? I mean, you could say, well, you take away the B cells, but the fibroblasts, they just do their job and they continue to make all the mess, right? And it's not that easy. There is such a dynamic interplay, and it can break apart. And I think we have to probably think also here a little bit more visionary. What can be actually repaired, right? Can we, I mean, when the tissue is completely destroyed, the alveolar structure, it will not be repaired. But to some extent, I think there can be repair. There can be lysis of matrix deposition, right? There can be actually a restructuring of skin architecture. There can be, for instance, a growth of vessels again, right, in the skin. And that is actually very interesting how tissue can be actually remodeled in a good way. And that's not completely understood, but that's actually a future research agenda. And having said that, I think at the end, still early therapy in severe patients better than late therapy, right? That's clear.
Yeah.
But
No,
I think we shift actually probably sometimes our endpoints and our expectations in the future.
Yeah, and particularly for our clinical colleagues listening in or maybe watching, I think it's worth remembering that the stroma is part of the host immune response. Think militia. And in an evolutionary sense, we've always known that the immune system and the tissue stroma have to be in a dynamic real-time relationship. And we also have known for a long time that for appropriate healing and tissue recovery, you actually need some inflammation. And so the whole evolutionary drive in the immune system in higher mammals and in humans has been to coordinate tissue response, tissue remodeling, and immune response to infectious insult. And I think what we may be seeing, Georg, is an evolutionary consequence of that, is that the reset principle allows the recovery of a manageable magnitude, if you like. What I mean by that, maybe just clarify, the immune system is quantitative. People forget that. But, you know, a really excessive quantity of immune activity is called sepsis. and the outcomes for that are very rarely good. And so I think the other thing that your work is reminding us of is that there's a quantitative element, and that may, if it can be overcome, we got that a bit from Carl June as well, actually, in the webinar, that the quantitative value of debulking an oncologic event. So I think you really are teaching us something about that dynamic immune stromal response. If Michael Brenner and Chris Buckley were here, they would say, you know, they tell you, oh, the stroma is, I don't know, maybe they might say it would be more autonomous than perhaps these data suggest. But I wouldn't dare to say that when they're not here to defend themselves. But what is finally absolutely clear is that the stroma immune system have crosstalk that matters. And just one final thing, Georg, I want to turn to before we close our conversation. In the webinar, a lot of people thought a little bit about risk-benefit ratio. And I wonder if I could just encourage you to think out loud a little bit about the risks. So a lot of clinicians, they're going to look at the conditioning. They're going to look at the adverse event profile, which we have seen in hem-oncology. And they're going to think, well, okay, what could go wrong? And that's appropriate, prima non nocere. So as clinicians, you and I, in all of our clinical studies over many years, have first and foremost had the patient safety at the front of our thoughts. So maybe just a few ideas, if you might, about the risks that might be attendant upon CAR T therapeutics.
Yeah, I think generally, I think cytokine release syndrome and neurotoxicity have always to be monitored, right? That's clear. We cannot, despite the higher grade cytotoxicities, CRS and neurotoxicity are rare, they can occur, right? And that's why one should be prepared to deal with them. The management of these toxicity, however, is very good, right? Despite, I mean, CRS is very well manageable, and just you need to know it, how to do it. And neurotoxicity is also manageable. And the two higher neurotoxicity events happen in the United States. They actually were very fast reversible. But it shows also that it can happen, right? And for instance, for neurotoxicity, we use a standard anti-epileptic therapy for some time after CAR T-cell therapy, which is, I think, preventing that. And so I think there is to develop actually good protocols how to use CAR T-cell therapy is of course needed to prevent and manage these toxicities. Infections are always playing a role, right? I mean, you go through a conditioning where you have a short B-cell inhibition followed then by a B-cell aplasia. So the infections always need to be monitored. However, what is quite interesting for me is that after 3 months, you get the B cell back, right? So basically, you have only a short phase where you have a compromised immune system, but then you actually have a reconstituted B cell system, at least naive, but it would be the response to vaccination. So in the long run, actually, due to the fact that you have no glucocorticoids, no continuous immunosuppression, and a reconstituted immune system, that could be extremely interesting, right? For that, the long-term infection is pretty good, right? And we didn't see even after 3 years, actually, that these patients are particularly prone to higher grade of infection, which is quite interesting. And the other component, which I think is very interesting, is the fact that family planning, pregnancies, right, are also an issue which has not been so much addressed in oncology because they have also chemotherapy. They're often not able to, they're not fertile anymore. But this plays a very big role, I think, especially in autoimmune diseases, because mostly young women are affected. And if they are drug-free, their freedom, right, to start a family and is, I think, much higher. So there are pros and cons, right? I mean, I think that the procedure is challenging. It's not a pill, right? It's a complex procedure, but also if it's only once in life, then it's interesting, right? If you have to repeat it often, it doesn't work.
Yeah, you know, and that's why I think there is interest in other approaches to deeper B cell depletion, which are potentially less onerous on the patient. I think they're almost certainly a discussion for another day. But that concept of, well, you know, I sometimes imagine an area under the curve of immunosuppressive risk, and whether that is accrued in a short period of time or over a much longer duration, even though if you like, the peak may be a little lower than one is experiencing after some immunoconditioning or preconditioning. Of course, we're very bad at defining immunocompromise, and that's something we learned during the COVID pandemic. And I think also that this CAR-T exploration is going to require us as a discipline to start thinking very well about how do we actually measure fundamental immune function, and its competence or otherwise. So many questions. Georg, unfortunately, we're kind of out of time here. I could, and we have demonstrated this to be true, you and I could talk for hours about this. I've thoroughly enjoyed learning from you, chatting to you, getting your insights. I'm absolutely certain that those who have tuned into the podcast will share my view. And for that, I, on their behalf, thank you. But honestly, on my own behalf, it's been great to have you with us, Georg. Thanks ever so much.
Thank you, Iain. Really nice to chat with you. Yeah.
It always is. And to you who are listening in or watching the podcast, hope you found this highlight session. Of course, the real thing is the webinar itself. So please pop along to imidforum.com, imidforum, all one word.com. You'll find this amazing webinar. You'll be able to listen to other podcasts. Of course, there's also a ton of other data there. We summarize lots of the current papers in the immune disease field. There are slide summaries of them, abstracts, translations, that will be, I hope, speeding you through the literature and giving you that necessary information to optimize the care of our patients, who at the end of the day are why we do this. So look, Georg, thanks ever so much. Look forward to seeing you in person next time round, Georg, and wishing all of our listeners and viewers the very best of luck in the care of our patients. Thank you for your attention. Bye for now.